Hi, my name is Helen McCarthy. I'm an accredited practicing dietitian and an academic. I work out of Victoria University in Melbourne. I'm really sorry I can't be with you this afternoon, and I hope you've all had an amazing conference. Over the next few minutes, I'm going to explore how we can advocate for nutrition awareness and nutrition education of other health professionals at a local level. I'm going to use a couple of examples from my own experience. They're not rocket science. You're probably all doing similar things in your own space. But it's just to show you how we can make a difference locally if we put our minds to it. So the first example is our pediatric and neonatal surgical units in the hospital that I worked in the UK. When I took over that team as their dietitian, there was no funded service to the neonatal gastrosurgical ward, but the children were then at around 12 to 18 months transferred to the pediatric surgical ward. So I was picking up children at 12 and 18 months old that were on some unorthodox feeding regimes and had some very poor nutrition related outcomes, such as neurological deficits that were as a result of chronic nutrient deficiencies, and also very, very poor feeding behaviors. Added to that, we had a rather controlling surgeon, so there was quite limited autonomy for the dietitian or for any member of that surgical team. The surgeon wanted everything run by him, every aspect of the patient's care, which is understandable when you think he's ultimately responsible. But when it comes to you and one of the senior medical staff and one of the senior nursing staff phoning him on his mobile when he's in Vatican City, it is a little extreme. So I decided that I needed to do something, one, to make the team more aware of what a dietitian could do, but two, also to make them aware of the role that nutrition played in the types of patients that they were dealing with. So to do that, I started inviting myself onto ward rounds and onto team meetings. I used to go to the neonatal gastrosurgery ward twice a week, even though there was no funded surgery service. But the reason for doing that was because those children were ultimately going to come into the service that was funded, but with big problems that we then needed to try and fix. So I wanted to try and preempt them. I used to go with the surgical case notes and to the surgeons and say, tell me what you've done to this gastrointestinal tract so that I know what I'm working with when I'm trying to think about what we can do to support this child's nutrition. Constantly being at these meetings, eventually it came out that we would undertake some clinical audits. So we audited our PN use. We audited the nutrition adequacy of what the children were receiving, both enterally and parenterally. And through these audits, we were able to make changes and improve the service. One of the changes that was made was we developed some ward-based nutrition procedures around what would be done in terms of prescription of parenteral and enteral nutrition. And that actually ended up with the responsibility for signing off on any unique prescriptions or bespoke prescriptions was done by me rather than by the surgeons, which is what it always had been previously. It also resulted in me being invited to give regular training sessions to the medical and nursing staff on different aspects of nutrition for the different types of conditions that the children were coming through the wards with. And eventually, after a couple of years of doing this, we ended up being able to secure funding to provide a service to the neonatal GI surgery ward, which basically doubled the workforce that we had in that area, and it has since been able to increase because the precedent has already been set. The second example I have is around malnutrition and nutrition screening, and basically this came out of a problem that I'm sure all of you have encountered, that Friday afternoon, 4 o'clock, you think you've done everything, you think you've got every I dotted and every T crossed, and you're just clearing up the desk, planning to go home on time for a change. And the phone rings, and it's the ward. And it's a patient that what you saw on the ward in the morning, that you asked questions about in the morning, and it's, oh, we weighed them after you left. They've lost weight. But we've decided we're still going to send them home. So their parents are here. Can you come and talk to them? On one wet, cold, windy winter's Friday afternoon, I got one of these calls and I went, that's it. We've got to do something. I cannot deal with this anymore. Because not only were the late referrals coming through, but we were seeing children sitting on the wards for longer than they should be because they were losing weight, because they weren't necessarily being referred in a timely manner, because they weren't responding to treatment, because they weren't being seen about their nutrition from the outset. So I got a team together that included medics, nurses, pharmacists, dietitians, and we sat down and we brainstormed how we were going to solve this problem. We undertook some audits to look at what our current practice was, and out of that we developed, validated and implemented the STAMP screening tool. And what that has subsequently resulted in is, because the entire team has ownership of the screening tool, there's mandatory training on nutrition and nutrition screening and referral pathways to the dietitians that the ward staff have to undertake every 12 months. We saw increased timely referrals, more appropriate referrals, so you were seeing patients that you needed to see when you needed to see them. We saw a raised awareness of nutrition across all the wards, and we saw the ward staff taking on more responsibility to actually start to talk to the families about nutrition and about what the children were eating in more detail than previously. And as a result of that, we actually went on to develop some first-line ward-based resources that the staff could use to talk to families before making a referral to the dietitian. So not necessarily increasing the dietitian's workload, but just raising the profile of nutrition across the board. Now, those are two really quick, simple examples. You probably all have a number that are buzzing around your head right now. But my take homes from those, when I sat down and thought about what did I do that made a difference in those situations, it was these 4 things. Be seen and be heard. I made my presence felt. I went on ward rounds. I invited myself to case meetings. I talked to people. I was always attempted to be positive, even when they were coming to me and doing things with these unorthodox regimes that would make your hair curl. I was trying, okay, so we've tried that and it hasn't quite worked the way we wanted to, so let's see what else we can do to try and improve on that, or to try and build on that. So it was always trying to be positive rather than stamp my little foot and scream, which is what I was doing inside. Be bold, take the initiative, talk to people. Have you thought about this? Such and such a patient hasn't actually been referred to us, but I'm just looking at them and making your presence felt, suggesting training. Can we do an audit of this? Can I come and talk to you about this, what I can do, what I can provide to your service? Be a team player. None of this would have been achievable if I hadn't have been part of a multi-professional team at all times. And I mean really be a part. Be on the wards, be talking to them, not just fly in, do what I needed to do and fly out again. Talk to them, get to know the staff, let them get to know me, so that they don't see me as a threat, they don't see me as undermining, they see me as part of their team providing a service to their patients. I hope you've been able to take something from this that you can turn into practical things in your own area. Thank you for your time and for listening.